Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 208 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the first question reads, TMC, a 77-year-old female patient presents to your accident and emergency department with a chief complaint of productive cough. She has an altered mental status. She is oriented only to person. She has a past medical history significant for type 2 diabetes mellitus, and severe COPD. On physical exam it is established she has a productive cough. Her pertinent vitals include a body temperature of 101.8 degrees Fahrenheit, a heart rate of 95 beats per minute, a respiratory rate of 33 breaths per minute, a systolic blood pressure of 105 mm of mercury, an SpO2 of 91% on oxygen at 2 liters per minute by nasal cannula. Some of her pertinent labs include a serum creatinine of 1.3 mg per deciliter and a BUN of 55 mg per deciliter. On her chest X-ray, there is extensive consolidation in the right lower lobe of the lung. Calculate TMC's CAB-65 score. Is the score A, 5, or B, 4, or C, 3, or is it D, 2? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, 4, and I will explain why. CAB-65 is a severity of illness score composed of the following criteria: confusion, uremia, that is a BUN above 20 mg per deciliter, respiratory rate equal to or more than 30 breaths per minute, low blood pressure, systolic blood pressure below 90 mm of mercury, or diastolic blood pressure equal to or less than 60 mm of mercury, age 65 years or greater. 1 point is assigned for each criterion met. This patient's CAB-65 score is 4 based on 1 point each for confusion, uremia, respiratory rate, and age 65 years or greater. This score is indicative of severe community-acquired pneumonia. Please advance to the next question. And the next question reads, in collaboration with the healthcare team, you're developing a community-acquired pneumonia standard order set. According to the guidelines from the Institute for Safe Medication Practices, abbreviated as ISMP, which of the following is an appropriate recommendation for your order set? Is it A. Include directions for completing the order set at the bottom of the form or screen? Or B. Use lowercase lettering for all medication names? Or C. Allow antibiotic doses to be prescribed as a volume or number of vials? Or is it D. List the most common or preferred drug first if multiple options are available? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. List the most common or preferred drug first if multiple options are available. When developing a standard order set, ISMP recommends listing the most common or preferred drug, strength, and dose first if multiple options are available for selection. In a standard order set, doses should not be prescribed as a volume or number of vials. Instead, a metric dose should be prescribed. In a standard order set, tall man lettering should be used for medication names on the organization's list of look and sound alike drug names and those on the FDA and ISMP lists of look-alike drug names with recommended tall man letters. In a standard order set, the directions for completing the order set should appear at the top of the form or screen rather than the bottom. Please proceed to the next question. And the next question reads, CMB, a middle-aged male patient is receiving parenteral nutrition secondary to an ileus. CMB's nasogastric output has been about 3 liters per day for the past 3 days. Currently CMB's arterial blood gas values are pH 7.5, P, C, O2 of 44 mm of mercury, P, O2 of 95 mm of mercury, and a bicarb of 45 milliequivalents per liter. After appropriately supplementing the phosphates, which of the forms listed below would you recommend for the anions for his sodium and potassium salts? Would it be A. 1/2 chloride, 1/2 phosphate? Or B. 1/2 chloride, 1/2 acetate? Or C. all chloride? Or would it be D. all acetate? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. all chloride, and I will explain why. The chloride to acetate ratio is adjusted in the parenteral nutrition formulation based on the patient's acid-base status. Acetate is a precursor to bicarbonate, therefore, acetate should not be recommended for the salt form for this patient with alkalosis. This patient will benefit from the use of all chloride anions because of significant nasogastric losses of chloride and his current alkalosis. If a patient has a normal acid-base status, it is reasonable to provide 1/2 anions as chloride and 1/2 anions as acetate. Providing 1/2 chloride and 1/2 acetate is inappropriate for this patient because of his alkalosis. The appropriate phosphate dose was already added, therefore, adding the anions as 1/2 chloride and 1/2 phosphate is inappropriate for this patient. Please progress to the next question. And the next question reads, DSP, a 47-year-old female was admitted 4 days ago for management of hypercalcemia and a left lower lobe infiltrate on chest X-ray. Her current medications include chemotherapy for breast cancer. DSP was intubated and admitted to the medical ICU. Her current regimen is vancomycin, cefepime, and levofloxacin. Her other medications include lorazepam, pantoprazole, unfractionated heparin for venous thromboembolism prophylaxis, and normal saline. DSP has developed a Clostridioides difficile infection. So my question to you is, which of the following are risk factors for DSP's initial Clostridioides difficile infection? Are they A. length of hospital stay, levofloxacin, and pantoprazole? Or B. receipt of cefepime, levofloxacin, and pantoprazole? Or C. advanced age, and receipt of cancer chemotherapy and levofloxacin? Or are they D. receipt of cancer chemotherapy, cefepime, and levofloxacin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. receipt of cancer chemotherapy, cefepime, and levofloxacin. Risk factors for initial Clostridioides difficile infection include advanced age, long duration of hospitalization, and exposure to antimicrobial agents and cancer chemotherapy. Antimicrobial agents that are known offenders include the third and fourth generation cephalosporins, fluoroquinolones, and carbapenems. This patient's receipt of cancer chemotherapy, the fourth-generation cephalosporin cefepime, and the fluoroquinolone levofloxacin are risk factors for her initial Clostridioides difficile infection. Her age of 47 is not advanced, and her 4-day hospitalization is not long. Proton pump inhibitor use may be a risk factor for recurrent Clostridioides difficile infection, but it is not a risk factor for this patient's initial infection. Please proceed to the next question. And the next question reads, KJP, a 27-year-old male patient presented to your accident and emergency department with complaints of nausea, abdominal cramping, and bouts of vomiting. He has a past medical history significant for Crohn's disease. Peritonitis was identified during the diagnostic workup, and empiric treatment with piperacillin, tazobactam was initiated. After a few days, KJP began experiencing high-volume diarrhea. His pertinent vitals at that time included a blood pressure of 82 systolic 45 diastolic, and a heart rate of 98 beats per minute. The medical resident suspects Clostridioides difficile infection, and sends a stool sample for culturing and toxin testing. The resident asks you to recommend an empiric treatment regimen for Clostridioides difficile. So my question to you is, which of the regimens listed below would be the most appropriate based on the 2017 Clinical Practice Guidelines for Clostridioides difficile infection in adults and children from the Infectious Diseases Society of America (IDSA) and Society for Healthcare Epidemiology of America (SHA)? Would it be A. vancomycin 500 mg orally 4 times daily plus metronidazole 500 mg IV thrice daily? Or B. vancomycin 500 mg orally 4 times daily? Or C. fidaxomicin 200 mg orally twice daily? Or would it be D. vancomycin 125 mg orally 4 times daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. vancomycin 500 mg orally 4 times daily. According to the 2017 IDSA/SHA Clinical Practice Guidelines for Clostridioides difficile infection, vancomycin 500 mg orally 4 times daily is the treatment of choice for an initial episode of Clostridioides difficile infection in adults like KJP with hypotension. Vancomycin 125 mg orally every 6 hours is the recommended dosage for an initial episode, non-severe or severe, not for an initial Clostridioides difficile infection with hypotension. Fidaxomicin 200 mg orally twice daily is the recommended dosage for an initial episode, non-severe or severe, not for an initial Clostridioides difficile infection with hypotension. Vancomycin 500 mg orally 4 times daily is the treatment of choice for an initial episode of fulminant Clostridioides difficile infection in an adult like KJP with hypotension. Clostridioides difficile is considered fulminant in the presence of hypotension, shock, ileus, and megacolon. Metronidazole should be added if ileus is present. It is unnecessary for KJP who does not have ileus. Please proceed to the next question. And the next question reads, which of the treatments listed below for adults with multiple recurrent Clostridioides difficile infections has the strongest level of support in clinical practice guidelines from the Infectious Diseases Society of America (IDSA) and Society for Healthcare Epidemiology (SHE)? Is it A, vancomycin plus metronidazole, or B, pulse and tapered vancomycin regimen, or C, oral fidaxomicin, or is it D, fecal microbiota transplantation? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, fecal microbiota transplantation. According to the 2017 Clinical Practice Guidelines for Clostridioides difficile infection in adults and children, 2017 update by IDSA and SHE, the strongest literature support for treatment of multiple recurrent Clostridioides difficile infections is for fecal microbiota transplantation. Fidaxomicin and vancomycin may be considered, but the level of support is weak. Metronidazole should be used as an alternate when vancomycin or fidaxomicin are not available for use. Please progress to the next question. And the next question reads, JWB was admitted to your general medical ward for hypertension management 6 days ago. Today JWB was transferred to the medical ICU due to increasing shortness of breath and an oxygen saturation of 82%. Upon arrival, she was intubated and the critical care team who began a workup for hospital-acquired pneumonia, abbreviated as HAP. So my question to you is, which of the following should be included in the diagnostic workup for JWB based on Infectious Diseases Society of America (IDSA) and American Thoracic Society (ATS) clinical practice guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia? Should it be A, sputum culture and gram stain, or B, sputum culture and clinical pulmonary infection score abbreviated as CPIS, or C, sputum culture? Or should it be D, bronchial alveolar lavage fluid culture and protected specimen brush tip? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, sputum culture. For both HAP and ventilator-associated pneumonia (VAP), the current guidelines recommend non-invasive sampling with semi-quantitative cultures. There is no evidence that invasive microbiological sampling with quantitative cultures, e.g., bronchial alveolar lavage fluid culture, improves clinical outcomes in patients with HAP, so it is not recommended. There is no evidence that invasive microbiological sampling improves clinical outcomes compared with non-invasive sampling, e.g., sputum culture, in patients with HAP. Non-invasive sampling may be done quickly and more economically, and it is recommended. The CPIS is a semi-objective assessment. Based on the current literature, the specificity and sensitivity of the CPIS are not high enough to justify its use as a diagnostic tool for HAP. The use of gram stain information to determine empiric therapy for HAP is unclear. There is some evidence that gram stain information may be helpful at the time when de-escalation is considered. Please proceed to the next question. And the next question reads, NRM, a 45-year-old male patient is admitted to your hospital and is diagnosed with hospital-acquired pneumonia abbreviated as HAP. He has already received 4 days of therapy with IV cefepime and gentamicin. His chest X-ray shows significant improvement. The oxygenation status is improved. According to his pertinent labs, the elevated WBC count persists with decreasing left shift. NMR has been afebrile over the past 1 day. His sputum culture turns positive for Enterobacteriaceae susceptible to all tested antimicrobial agents. So my question to you is, which of the following recommendations should be made for NRM now based on current clinical practice guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia from the Infectious Diseases Society of America (IDSA) and American Thoracic Society (ATS)? Should it be A. Discontinue all antibiotics on day 10? Or B. Discontinue all antibiotics on day 7? Or C. Discontinue gentamicin now and cefepime on day 7? Or should it be D. Confirm that the clinical pulmonary infection score (CPIS) is less than 3 and then discontinue all antibiotics? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Discontinue all antibiotics on day 7. The evidence to support the use of the CPIS as a diagnostic tool to be applied in the decision-making process for antimicrobial discontinuation in patients like NRM with HAP is inconsistent, so it is not recommended. De-escalation of dual antibiotic therapy to a single agent is supported if there is a negative sputum culture accompanied by signs of clinical improvement. However, this patient had a positive sputum culture according to current IDSA ATS guidelines. Antimicrobial therapy should be discontinued on day 7 due to the absence of data comparing short-term with long-term antibiotic therapy in patients like NRM with HAP. Evidence does suggest that use of a duration of therapy less than 7 days has no negative impact on the benefits from antibiotic therapy, but it does reduce antibiotic-related adverse effects. Please progress to the next question. And the next question reads, your consultant pulmonologist diagnosed JLA, a 47-year-old female patient with acute respiratory distress syndrome, abbreviated as ARDS, 7 days ago. So my question to you is, which of the therapies listed below would you recommend for JLA because it has shown some benefit in long-term outcomes in patients with ARDS? Would it be A. IV salbutamol therapy, or B. Oral ketoconazole therapy, or C. Early initiation of low-dose corticosteroids? Or would it be D. Early trophic enteral feeding? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Early initiation of low-dose corticosteroids. In a randomized, open-label study of patients with acute lung injury, there was no significant difference between full and trophic enteral feeding in ventilator-free days or 60-day mortality. Trophic feeding was better tolerated. Early initiation of low-dose corticosteroids is associated with improved morbidity and mortality in patients with ARDS. Therefore, this is the best choice for this patient. In placebo-controlled studies of patients with ARDS, no significant differences in ventilator-free days or mortality were demonstrated with the initiation of ketoconazole. In a placebo-controlled trial of patients with ARDS, IV salbutamol increased 28-day mortality. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 209.